that y'all have me wired for sound, I guess we're ready to go. What I wanted to do is present what is now recognized as kind of a new treatment approach to the type 2 diabetic individual, and that's a very comprehensive approach where we talk not only about treating their hyperglycemia, but also very integral associated medical conditions that include hypertension, which about half of all type 2 diabetics have, and also the dyslipidemias that are so prevalent among the type 2 patients. So this is going to be a very comprehensive review and also focusing on some special considerations in the geriatric diabetic. Now, how do I advance? Do I have a remote up here? Or you all do it from the back? Thank you. Yes. Right in back of you. Oh, okay. What's on the wall? Okay. All right, the ADA has provided for us very nice guidelines in terms of the glucose control for type 2 patients. And these are the guidelines that they've recommended in terms of glycemic control for type 2 people of all age groups. Now, certainly for the geriatric individuals, we're going to be shooting not for intensive or very rigid control, but more for in the acceptable or even fair range, simply because of the lack of autonomic responsiveness in elderly people in terms of detecting when they're becoming hypoglycemic. So for the past 2 years, we've had these guidelines to help us in terms of finally controlling diabetic individuals in terms of their glucose metabolism. And what we're recommending basically in the geriatric diabetic is that we shoot for a fasting glucose level that is a serum glucose value after approximately a 10-hour fast. That's approximately 140 milligrams per deciliter, a 2-hour value that's about 180, a glycosylated hemoglobin of approximately 8%, and in addition, as we'll see in a moment, integrally related to their defect in carbohydrate metabolism is also a very high incidence of problems with lipid measurements. And in the diabetic patient, geriatric and all comers, we're shooting for triglyceride values of 175 or less and total cholesterol values of under 200 optimally. Okay. Very quickly in our patient population, we realize that diet and exercise and weight loss are fairly futile interventions in normalizing their glucose values. I'm not saying that these should not be ongoing treatment modalities. Quite contrarily, we need to continue emphasizing the importance of dietary adherence and achievement of ideal body weight, because that's the most effective and certainly very benign treatment approach to any type 2 patient. But we don't wait weeks or months or years to control their glucose values with those non-pharmacologic measures. And in all type 2 patients, we fairly quickly move forward to include drugs in our effort to control their glucose values. And I wanted to spend some time going through the oral hypoglycemic agents that are available in the United States today, because this is one area in which certainly choices would have to be dictated by the specific patient, and absolutely in the geriatric individual, as we'd see, there are certain agents that we would want to shy away from. The oral hypoglycemic agents in the United States are classified as first and second generation drugs. The first generation drugs were released in the early 1970s and include in the U.S. Oronase, Tolinase, or Talazimide, and Chlorpropamide or Diabetes. These drugs are no longer widely prescribed in the private community. I think we use more chlorpropamide at this institution than is used at any other teaching hospital that I'm aware of, and we really need to get away from that. Particularly in the geriatric individuals, this is a dangerous hypoglycemic agent, and the main reason being its very long duration of activity. In an individual with normal renal function, chlorpropamide has an effective duration of lowering a serum glucose value that's 36 to 72 hours long. You can add a day or so in a geriatric individual who does not have a normal creatinine clearance simply as a consequence of their age. So this is a dangerous drug. The hepatic metabolites have hypoglycemic potential, so that even when the drug is metabolized from the parent compound, diabetes, to its metabolic agents, those agents also can have effect on lowering the serum glucose level. And each year at this institution, we see several elderly people who require hospitalization for intravenous dextrose to support their glucose following an accidental or intentional overdosage of chlorpropamide. So the ADA and the Joslin Clinic has gone so far as to say that in a diabetic person over the age of 55, diabetes is not an appropriate oral hypoglycemic agent. Now at the county, the age cutoff unfortunately is 65, and actually today I spoke with the pharmacy about dropping that age criteria to 55 from the present value of 65. So in the older type 2 diabetic, chlorpropamide is not a benign drug, mainly because of its long hypoglycemic effect. In the mid-80s, agents that are much superior to our first generation drugs were released, and the two that are available, actually three now in the United States, include glyburide, which is made by two pharmaceutical companies. Upjohn markets the drug under the name of Micronase, and Hirsch under the name of Diabeta. They're exactly the same agents. And glipizide, which is made by Pfizer and also is known as Glucotrol. These are the oral agents of choice in a geriatric type 2 diabetic who is controllable by a tablet alone. These are much safer drugs. They also are metabolized through the liver, but their metabolites do not have hypoglycemic potential. So once the agent goes through the liver on its initial pass, the drug is cleared and there's no further potential for hypoglycemia. The half-life of these agents is hours, 2 to 4 hours. They're very rapidly metabolized. But interestingly, they have an effective duration in terms of lowering serum glucose values of 12 to 24 hours. So very effective, but quickly metabolized, and their metabolites do not have hypoglycemic potential. In the world's literature, there's not a single convincing case report of a hypoglycemic death related to glipizide usage. And presently in the United States, the oral hypoglycemic agent of choice in a geriatric patient is glipizide because its half-life is the shortest, and it has a bimodal route of excretion, both hepatic and through the kidney. So for an elderly diabetic who's controllable on an oral agent, the number one choice would be glipizide. Okay, just comparing kind of as categories the first and second generation agents. If we use tolbutamide, which is one of the older ones, in terms of potency as a scale of 1, chlorpropamide is about 5 times more potent or effective in lowering glucose values than tolbutamide. And the second generation agents are several hundred times more potent. And this is a very interesting difference. Glipizide and glyburide, the newer ones, work not just by stimulating the pancreas to secrete additional insulin, but also work on the underlying abnormality in type 2 diabetes, and that is the problem of insulin resistance. And that's why they truly are much more potent or much more effective agents. And because of this added effect on insulin resistance, they, from a physiologic point of view, are clearly superior to the older drugs. And that simply is the point that's being made by this particular comment. The first generation agents work only by stimulating additional insulin release from the pancreas. Common side effects with the first generation drugs include an anabuse-like flush. If patients taking chlorpropamide go out and have a beer, they will experience a very unpleasant flushing experience, which actually I think is very beneficial. But patients don't like it, and they tend to be non-compliant with the first generation drugs because they can't drink while they're taking it. You don't have the anabuse flush with the second generation agents. In addition, again, mainly in the geriatric population, every year at Medical Center and the VA both, we have primarily elderly people admitted because of symptomatic hyponatremia, and clearly associated with use of chlorpropamide especially is a syndrome of inappropriate ADH secretion, in which patients have an acquired defect in free water clearance and develop a dilutional hyponatremia that may require hospitalization until the drug clears. And we commonly have patients, particularly geriatric individuals, coming in for seizures related to serum sodium levels of 118 to 120. There is no convincing case report in the literature of this problem with free water clearance in individuals treated with a second-generation drug. So again, clearly far superior. One of the contraindications to using any of the first-generation drugs is a prior history of hyponatremia or of congestive heart failure. And again, certainly considering we're dealing primarily with an older population, this is additional information why we should steer away from chlorpropamide. The first-generation drugs are ionically charged, and because they are electronically charged, they interact because of their charge with a lot of commonly used drugs. This includes Coumadin and high-dose salicylates, again, drugs that we may be using in a geriatric population because of histories of DVT or a valvular heart disease. And it will actually potentiate the effects of Coumadin, say, or of aspirin. So because of the risk of drug-drug interaction, again, the non-charged second-generation drugs are clearly superior, especially in geriatric individuals who are likely to be on these other agents. Okay, there's a lot to cover, so I wanted to kind of move through quickly and do an overview, again emphasizing treatment of an elderly type 2 patient. In terms of insulin therapy, usually if we can't achieve the glycemic control that we outlined on the first slide, we move fairly quickly to resorting to subcutaneous insulin and treating a patient. And the choices, again, in the United States are classified basically on the action of the different insulins. And in the US, we have 2 rapid-acting insulins that we can choose from. That includes regular and semi-lenti, which have very similar peaks and durations of effect. I think an important point to mention here, especially in people who are sight impaired and in your geriatric patient who may need pre-filled syringes, the only premix insulin that is stable for any duration of time in a syringe is semi-lenti and lenti. So if, for instance, we have a blind type 2 patient and we want to have a nurse practitioner go into the home and fill a week's worth of syringes, the only preparation other than premix, which we'll talk about in a minute, that would be stable for that length of time is a combination of semi-lenti and lenti. And that's an important point to remember. In terms of intermediate acting insulins, the choice in the US is between NPH and lenti. Again, very, very similar. They're essentially the same. The main difference is a protamine group that NPH has and is often the cause for local allergic reactions in individuals that do have cutaneous allergies to their insulin products. The only insulin, long-acting insulin in the US is ultralenti. This is clearly an insulin designed for use in a type 1 patient, is very inappropriate for use in a geriatric individual. So we'll simply make that point and move on. It's well known and I think fairly widely accepted that the most effective simple insulin regimen for any type 2 patient is the split mix regimen, in which the patient essentially takes 2 injections per day. Y'all are very familiar with this, I'm sure. One before breakfast, the second injection before supper. Each shot is a mixture of an intermediate acting insulin, either NPH or lenti, with a short acting regular. And I think if you plot a line across here, you'll see that individuals given this regimen have effective insulin coverage 24 hours a day. So this is an effective regimen. I still occasionally see patients that are treated only on a morning shot of NPH or a combination of NPH and regular. And I think, as you can see, those individuals are not being adequately covered for a great part of the day. Their effective insulin essentially is gone shortly after their evening meal. So if you want to effectively regulate any type 2 patient, the simplest regimen is the split mix. Okay, it's important also to be aware of the premix insulin preparations that are available in the US. And again, I think considering we're dealing with elderly people, these are a very promising option for your geriatric individual. We've actually quantitated the number of steps it takes to go through and mix insulin from an NPH in a regular vial, and it's about 7 or 8 steps. And if you have a geriatric person who has had a stroke or who is visually impaired, it's very common for them to mix up the NPH with the regular, or to mismix the insulins in a single syringe. And that's why the premix insulins were introduced in the United States. They've been used in Europe for a number of years and were so well accepted, Europe and Canada, that they were finally introduced into the United States. And the formulations that are presently out there and available are a premix of 70-30, which is 70% NPH with 30% regular. And then about 6 months to a year ago, Lilly made a very bold step, I feel, and released 50-50 insulin. And in my clinical experience, I've had no patient that I felt was suitable for 50-50. And certainly in a geriatric patient, I would never consider prescribing this insulin. Again, I think in terms of drawbacks, you have to realize that patients are getting a large percent of short-acting insulin. So it should be used only in a patient who's going to be sure that they eat shortly after taking the insulin, because this 30% of regular is going to kick in and they could suffer a hypoglycemic event if they don't eat following their subcutaneous insulin injection. So this was developed for use in the resistant, fairly obese type 2 patient, and is certainly a treatment option, especially in people who may have difficulty, for whatever reason, coordinating the many steps required to mix from 2 vials. And again, we don't use this in a type 1. There are some very old type 1s in the VA system especially, and we would not consider using that in them. Okay, with the introduction of the newer oral agents, there was renewed interest in combination therapy, or using a combination of insulin with an oral agent to achieve better control. And certainly theoretically, it would make sense that by combining insulin, which has a totally different modality of action in terms of lowering glucose, with an oral agent, that we should get very complementary effects and improve a patient's glycemic control. And so there have been a number of studies that have looked at that very issue, and it is a very viable treatment option, especially in the older patient. In terms of the benefit, one of the big benefits in type 2 people of all ages is reducing the overall dose of insulin required to normalize their blood glucose value. And with the understanding that the underlying problem in type 2 patients is actually very high circulating insulin levels and a defect in insulin action rather than insulin production, this is certainly a desirable effect, because we know high doses of insulin are going to be directly toxic, so to speak, to the vasculature. So it has a very major beneficial effect. And also, in terms of efficacy, you often can better regulate a patient on combination therapy rather than on high-dose split mix. So in the mid-80s, there was renewed interest, and there was a barrage of approximately 12 studies that were released that examined different ways of combining insulin and oral agents. Most of those studies were using traditional dosing of each, that is twice a day insulin, NPH usually, twice a day, and twice a day dosing of the oral agents. And all of those studies were extremely discouraging. They consistently showed that they did improve glucose control, but only for about 3 to 4 months. And in more recent years, and actually much of this data is unpublished and is kind of ongoing research in our division and many others, is a very promising alternative in type 2 patients, and that's what's been coined BIDS therapy. And that is a specific combination where we use bedtime insulin plus a daytime sulfonylurea, and hence BIDS therapy. And in this particular combination regimen, the patient is given a bedtime injection of intermediate acting insulin. And NPH has been used universally in the studies on these patients. And then we couple that on rising. They take a second generation oral agent in the morning. And studies on this particular combination have been extremely promising. And what they have shown basically is that in individuals taken from conventional twice a day insulin dosing to BIDS therapy, that we were able to reduce the total amount of exogenous insulin or insulin through the injections that they were receiving in order to improve their glucose control. And also, in terms of their fasting plasma glucose values, those individuals taken from split mix insulin to BIDS therapy showed a dramatic improvement that seemed to increase over time with combination therapy. Also, their glucose control was also documented by measuring the glycosylated hemoglobin, and this also improved in those individuals taken from twice-a-day insulin to BIDS therapy. Most of the studies have not been beyond 4 to 6 months, but unlike twice-a-day oral agents and insulin, this particular regimen appears to have long-duration favorable effects in terms of improving control overall. In terms of which patients are candidates for combination therapy, that's been very well defined. The more recently diagnosed type 2 patients are going to be better responders. The type 2 individual who's not morbidly obese, which is going to be many of the geriatric individuals, the individuals that don't have an exhausted pancreas, those people who still have detectable circulating insulin levels as measured by the C-peptide assay. That's a measurement of endogenous insulin production. And also oral agent failures. Instead of taking someone from a maximal dose of an oral agent straight to twice-a-day insulin, combination therapy is certainly a very viable option. One of the other biggest benefits is that you don't see as frequent or profound a hypoglycemia. And again, considering an older patient group, that's a very desirable effect. Okay, as I mentioned, this is going to be not just a discussion of controlling their glucose, because we now know that the type 2 patient has intimately related multiple metabolic problems, not just their defect in carbohydrate metabolism, but also related directly to their hyperinsulinemia, hypertension. And it's very important, we now appreciate, to treat their hypertension in a very patient-specific fashion. At the time of diagnosis of hyperglycemia, approximately 50% of individuals are found concurrently to be hypertensive. And we now know that that is due, again, to the underlying problem of high circulating insulin levels that characterize the type 2 patients. So clearly, diabetics, just because of the nature, particularly the type 2, are at increased risk for developing significant hypertension. We also know that the effects of their elevated blood pressure, their hyperglycemia, and their underlying problem of hyperinsulinemia, these are additive effects in terms of the development of very accelerated arteriosclerosis diffusely. And the ultimate cause of death in most diabetic patients is premature vascular disease. We know that each of these medical problems clearly contributes to that defect. So in recent months and years, it's been realized that we want to choose an antihypertensive agent for these people that won't just lower their blood glucose level, but also not adversely affect the other problems they have, specifically their glucose metabolism and their hemodynamic responsiveness. In other words, we don't want to blunt their adrenergic symptoms so that they would be unaware of a hypoglycemic event. So clearly there are a lot of special considerations when treating a hypertensive diabetic. I don't think anyone would argue with you. The data is very convincing that in terms of the vascular sequelae in a diabetic, we know that hypertension is a very important factor to delaying the progression of the microvascular small vessel changes, which include the retinopathy and the renal lesion or the diabetic nephropathy. Okay, when I was in medical school, I had drilled into me that this is how you treat any hypertensive patient, and I think some individuals are still approaching any hypertensive individual by this old stepwise treatment approach, where we begin with a thiazide diuretic, and once that's used at a maximal dose, adding a beta blocking agents. And that is how for many years we were treating diabetics and non-diabetics alike who were hypertensive. And then in the late 80s and early 1990s, there was a multitude of large clinical trials on managing hypertensive patients and the vascular outcome, in other words, the incidence of coronary events. And it revealed to us a consistent paradox that although we were normalizing blood pressure in these individuals, that there was absolutely no improvement in terms of coronary event outcome. And this was extremely discouraging to those of us that were faithfully treating patients. And then some physicians went back and looked more critically at these 11 published clinical trials, which had universally showed us this very grim finding. And it was found that coronary events, as defined by angina, MI, or cardiac-related death, were reduced in only one of these 11 studies. And that actually in 6 studies there was no improvement whatsoever, even though we were normalizing blood pressure, in terms of coronary event outcome. And in actually 4, there was an increased incidence of coronary-related events. So this was very disturbing. And further examination of these trials was done. And what it was realized is that the physicians conducting these trials followed their medical school pharmacologist's advice and were treating with the stepwise approach. Patients were started on a thiazide diuretic that was treated maximally to a maximal dose, and a beta-blocking agent was added if blood pressure control wasn't achieved. And what we were doing is basically, and this is especially true of the elderly people, we were unmasking genetically predisposed glucose intolerance in many of these individuals. And this is a table of relative risk for developing hyperglycemia. And if you take an individual with hypertension and give them a diuretic agent, they have a much greater risk for developing clinically significant glucose intolerance than a normotensive individual does. If you treat them with a beta blocker as single therapy, their risk is even greater because that has even greater effects on carbohydrate metabolism. And if you treat them with the additive therapy of a diuretic plus a beta blocker, these individuals had a many-fold increased risk for developing a defect in carbohydrate metabolism that would require clinical intervention. So basically, we were not doing these people any favor. And what was finally realized is that by treating them with conventional agents, we had partially and in some cases completely canceled the beneficial effects of normalizing their blood pressure. And what we were doing instead is creating other problems. And in looking critically at the laboratory data collected on these patients in these trials, it was found that these people, many of whom were elderly patients, had developed defects during treatment in serum lipid levels, had developed glucose intolerance where previously they had not, electrolyte abnormalities, hyperuricemia, a multitude of metabolic derangements that were not present prior to treatment intervention. In addition, beta blockers particularly had adverse effects on the cardiovascular system that included left ventricular hypertrophy. So clearly we were not doing these people any benefit. And the thiazide agents, any potassium wasting diuretic, the most common one of which is prescribed as a thiazide diuretic, we now know has a direct adverse effect on the effects of insulin in any patient. And what you see in a diabetic person treated with a thiazide is actually suppression of insulin secretion, so that these people have blunted production of insulin from their own pancreas. In addition, there's significant worsening in the action of insulin within cells. So glucose metabolism deteriorates fairly significantly in individuals treated with any potassium wasting agent. It's not true, and let me emphasize, with non-thiazides or any potassium sparing diuretic, you don't see these metabolic effects on carbohydrate metabolism. Beta blockers were the next step drug that most people were using. Again, there's an effect both on insulin production and also blunting of a patient's awareness of a hypoglycemic event, particularly in elderly individuals who already, simply as a consequence of their age, have blunted autonomic responsiveness. If you add a beta blocking agent on top of that, someone that you're treating with an oral agent or insulin and trying to regulate tightly, they would have hypoglycemic events and be totally unaware that their glucose level was low. So both adverse effects on glucose metabolism and loss of the warning symptomatology of hypoglycemia. And they also, as I mentioned, have effects on insulin secretion and increase glucose production from the liver, which already is an abnormal underlying problem in any type 2 patient. So really very significantly adverse effects from a metabolic point of view. The other disadvantage beta blockers have is that both the cardioselective and non-cardioselective have significant adverse effects on the lipid profile. And as we'll see in a moment, the most common lipid abnormality in all type 2 individuals, regardless of their age, is hypertriglyceridemia and a low HDL. And we know that that's a risk factor in and of itself in a diabetic for premature coronary disease. And there is a 20% to 25% increase in triglyceride levels in diabetic patients treated with beta-blocking drugs, and approximately a 10% decline in an already low HDL level. So both adverse effects on glucose metabolism and on the lipid profile. Okay, the agents of choice, both in the younger and older type 2 patients, without question, are the ACE inhibitors and calcium channel blockers. These drugs, as a rule, are what are considered some renally protective. Both improve renal blood flow, and in type 2 patients of all age categories, this is a very desirable effect to increase renal perfusion. The calcium channel blockers are particularly desirable to use in a hypertensive diabetic with coronary disease because they are cardiac protective. They, as a class of drugs, improve coronary blood flow and improve myocardial perfusion, and also cause left ventricular hypertrophy regression. There are also a number of cath studies that show regression of plaques in coronary vessels in individuals treated with calcium channel blockers. So metabolically, they have no adverse effect and are cardiac protective. The ACE inhibitors are ideal for patients with no known coronary disease and who may have early diabetic nephropathy, even microalbuminuria or early wastage of protein. And these drugs improve renal blood flow even much more potently than the calcium channel blockers, and will actually decrease proteinuria and clearly delay the progression of the renal lesion in all patients treated with ACE inhibitors. Okay, so at the present time, there are very few studies looking at cardiovascular mortality and treatment of hypertension in diabetics, regardless of the age group. The data just is not out there. But from a theoretical point of view, in terms of considering the effects on glucose metabolism, their lipid profile, renal perfusion data, and also in terms of their cardiac status, converting enzyme inhibitors and the calcium channel blockers are clearly the drugs of choice. And again, this is somewhat of a summary slide trying overall to look at the different classes of antihypertensive drugs from the metabolic perspective. There are some studies on ACE inhibitors, primarily captopril, which show an actual improvement in insulin resistance or the effectiveness of insulin at the level of the cell. And there are several studies that show patients' glycemic control improves when they're treated with an ACE inhibiting agent. Okay, I wanted briefly to mention also some information about the lipid abnormalities. And in terms of the geriatric patient, I think this is a very controversial area as to how aggressively to treat lipid abnormalities in a geriatric individual. But the trend universally is one of increasingly treating them with pharmacologic agents in hopes of improving the duration and quality of their life. There have been a number of studies on the incidence of dyslipidemias in type 2 patients. Only about 3, the World Health Organization study, which was a multinational study, and that showed that there was about a 20% increase incidence of hypercholesterolemia and hypertriglyceridemia among the diabetic population as compared to the non-diabetic. The diabetes intervention study was an examination of German individuals with diabetes, and compared to the control population, also German individuals, there was a twofold increase in the incidence of lipid abnormalities among the diabetic patients. The Framingham study here in the U.S. gave us a similar statistic, about a twofold increase incidence over the non-diabetic population, and this study identified the lipid profile which is most prevalent among the type 2s, and that is a high triglyceride and a low HDL. In terms of the Mexican-American population, that data is actively being collected, and it looks like the incidence of lipid abnormalities in the Hispanic type 2 diabetic is anywhere from 35 to 45% higher than among the non-diabetic Hispanic individuals. So it's very, very, very high. And this is fairly new awareness. Okay, in terms of the most common profile, again, I've already mentioned in the type 2 patient, the primary problem is high triglyceride and a ominously low HDL. And I've seen HDL levels that are non-detectable in type 2 individuals. But unfortunately, you can see a spectrum of lipid abnormalities in any type 2 patient, regardless of the age group. They may have a combination of high cholesterol and also high triglyceride, and those are particularly challenging patients to manage. There's a lot of dispute as to whether or not hypertriglyceridemia, regardless of the age, is a risk factor for premature coronary disease. And in the diabetic, that is not a point of issue. The World Health Organization study very clearly showed us that hypertriglyceridemia in a diabetic is a risk factor for premature coronary disease and warrants pharmacologic intervention. So it's more of a controversy in the non-diabetic than it is in the diabetic. And in terms of treatment, again, we're becoming increasingly aggressive with not just treatment parameters, but also with treatment interventions. Again, also regardless of the age, you need to have ongoing, just as with the glucose control, ongoing reinforcement of non-pharmacologic modalities. If you could get patients to achieve ideal body weight, most of the problems related to their high insulin state would reverse. So this needs to be ongoing intervention. But again, as with glucose control, we resort fairly quickly to pharmacologic modalities. You will see a significant improvement, 10 to 20% in triglyceride and HDL levels only by intensifying their glucose control, by improving their glycemic control. It'll have a significant impact on their lipid profile. But again, quickly, and it's no longer so much a factor of age, we're going to lipid-lowering drugs, even in the older individuals. In terms of the choice of lipid-lowering drugs in the U.S. today, it's really very easy to treat their dyslipidemias. If the patient has the usual lipid profile that you see in a type 2 patient, their problem is primarily an elevation of VLDL cholesterol. And the two drugs of choice that target that specific abnormality available in the U.S. are going to be nicotinic acid and the fibric acid derivatives. Here, this is going to be gemfibrozil, basically. That's what's available in the U.S. Nicotinic acid is very potent in terms of lowering total triglyceride levels and raising HDL, but it has an adverse effect on glucose control, and therefore in a diabetic is not the agent of first choice. Even in light of the recent studies released from the Helsinki Heart Study, gemfibrozil remains the agent of choice for a hypertriglyceridemic diabetic. If your patient is unfortunate enough to have a combination of high cholesterol and triglyceride, where they also have a problem with a high LDL cholesterol, your treatment choice is going to be basically between a bile acid sequestrant or an HMG-CoA reductase inhibitor, and that includes Mevacor, simvastatin, and pravastatin in the United States. And again, in a diabetic individual, your choice is going to be largely as a first agent to go with an HMG-CoA. The reasons being severalfold. Bile acid sequestrants tend to impair absorption of things from the gut, and if you have a type 2 patient, especially an older type 2 patient who has gastroparesis or who is a polypharmacy patient who's on a lot of different drugs, they may not well absorb their drugs if you treat them with a bile acid sequestrant. The other problem with this class is that these drugs tend to raise triglyceride levels. So certainly not a desirable side effect of a drug in a diabetic patient. So if the primary abnormality is with LDL cholesterol, we tend to go with one of the HMG-CoAs. And again, there's a great deal of issue or dispute as to how aggressive to treat the geriatric patient, diabetic patient with a high LDL, and that's why Mevacor in the 10 milligram form was basically released. It's for the geriatric individual and also for the heart transplant patient, where we really want the effect on LDL cholesterol without giving them a full 20 milligram dose. Okay, so let's kind of summarize things briefly. If you can get patients, regardless of their age, to achieve ideal body weight, that's the optimal treatment approach. And certainly in an elderly individual where you have to worry about toxicity of drugs and side effects, that would be the ideal way to treat them. Unfortunately, it's not usually effective therapy. In terms of glucose tolerance in a geriatric patient, hemoglobin A1C of less than or equal to 8%, fasting blood glucose of I'd say 140 or less in a type 2 patient. And again, you're going to have to use clinical judgment if you have a very elderly individual who has autonomic unawareness. You would not want to be as tight with them as someone who is very aware of fluctuations in their glucose levels. Always, and particularly in an elderly individual, you'd want to treat with the lowest dose possible of either insulin or oral agents, and certainly entertain combination therapy in these people. In terms of their blood pressure, it's now fairly universally accepted that the target blood pressure in a hypertensive diabetic is not 140 over 90, but is 130 over 80. And again, you may not want to be as rigid in an elderly individual, but for most type 2 patients, that's what we're treating too. We avoid drugs that are going to have adverse metabolic effects, particularly on glucose metabolism, and those drugs are beta-blocking agents and any potassium-wasting diuretic. We choose instead drugs that are metabolically neutral, and those include the alpha-blocking drugs, which I haven't talked a lot about because they're not terribly well tolerated in geriatric people. But those include things like clonidine and Cardura. But a better class are the calcium channel blockers, which are well tolerated by all age groups. And the ACE inhibitors are the antihypertensive drugs of choice in those individuals without coronary disease and or with proteinuria. And finally, in terms of the lipid abnormalities, we have specific target parameters, and these are probably going to be redefined, but total cholesterol level, regardless of age, 200 or less, as with triglyceride, and this actually has been specifically defined to 180 or less. HDL cholesterol of over 40. LDL cholesterol, just as of January, in a diabetic, the target value now is 100. Again, that's because of the additive problems of the hyperglycemia, hypertension, and the lipid abnormalities. We would avoid nicotinic acid and the bile acid sequestrants because of their specific adverse effects, and choose instead between the HMG-CoAs, which we would use in an individual with a primary problem in LDL cholesterol, or fibric acid derivatives, specifically gemfibrozil. And basically, this treatment approach hopefully will show us an improvement in coronary event outcome. And there are studies that are ongoing now using this more comprehensive treatment approach in type 2 patients of all age groups to see if we do have an improvement in coronary event outcome. And it was felt when the studies were done in the late 80s that we were treating the tip of the iceberg, so to speak. We were treating blood pressure, their glucose intolerance, their lipid abnormalities, and their obesity not aggressively enough, and not considering the interactions between these different entities. And that's why we had made no impact in coronary event outcome. That's all I had. I wanted to leave a few minutes in case there were any questions. Oh, we're very quiet. Come on.